everybody, and thanks for the GIS for choosing such an important topic. I followed great speaker who talked about techniques. Now it's about prediction, and you can only imagine how when you add aortic stenosis to the mix of left main disease. So the combination of left main disease with aortic stenosis adds significant hemodynamic compromise for the procedure. And most of us as an operator will be faced with the scenario where you will have a patient who is sent for aortic stenosis and coronary artery disease. In answering the question from the literature, we look for some guidance, but unfortunately, I might leave you with some more questions towards the end of the first part of the talk. So, do we do it pre-TAVR, during the TAVR, or post-TAVR? That's an important question when we discuss stable left main disease outside the rim of aortic stenosis. So we look for some guidance, and most of the published report was around stable coronary artery disease. I picked this one from the TVT, where they looked at more than 49,000 patients with underwent transcatheter aortic valve implantation, and they looked at their outcomes in relation to whether or not they have any percutaneous intervention 30 days before the procedure or 3 months, up to 3 months before the procedure. I want to just highlight that 84% of the patient underwent PCI prior to TAVR, 14% underwent PCI concomitant to the TAVR procedure, and 1.3% during after the TAVR procedure. Most of those patients have stable outcome. The low number of the patients who underwent PCI during the TAVR did not allow for a direct comparison, but if you look to the right of the screen, the outcome of those patients are comparable across all, except when you compare patients who underwent PCI in a stable coronary artery disease before TAVR versus during TAVR, definitely pre-TAVR was better for stable coronary artery disease. Now, another scenario or another important question for us clinically are whether or not to revascularize concomitant versus pre-TAVR procedure, and this is based on a meta-analysis of smaller study, but the conclusion of this was mortality favoring before TAVR. Cardiovascular mortality is the same, myocardial infarction is the same. The only signal that will be concerning for the operator is the risk of bleeding was higher in patients who underwent pre-TAVR PCI due to bleeding. Now, randomized data did not help with the question about left main, and I will come to that later. But if you look at the activation trial, specifically addressing revascularization in stable coronary artery disease, one of the exclusion criteria was left main, ACS, and CCS class 2 angina. This can be used as guidance for operator to whom that we should not consider to generalize the result of this trial. But more importantly, this trial did not show any difference between the two arms, but it did not meet its non-inferiority mark. So this trial was considerably an equivocal trial. It will help the operator for certain patient who does not fulfill that criteria, that if you want to revascularize before TAVR, it's still safe. Now, the most important trial was the Notion 3, and for that trial specifically, I want to highlight a couple of points. It's a low-risk trial. If you look at the syntax score, it's definitely not a complex disease. Left main was excluded, and the majority of the procedure was done pre-TAVR. Concomitant was I would say, more than after TAVR. So the majority of the revascularization happened before the TAVR procedure or during the TAVR procedure. The death was no different between the people who received conservative management or PCI. With the exception of people who have proximal disease, there has been definitely a trend towards favorable outcome due to the combined effect driven by repeat revascularization. So does that help us with the left main? Absolutely not. Now, the only piece of information that might, for the practitioner, might be helpful is the left main TAVR registry. They were tasked to ask a simple question: if a patient had a PCI before TAVR, does his outcome similar or worse than a patient who underwent TAVI but without prior left main disease? And basically, they did a match analysis, a match case study, and out of the 176 patients who underwent bland left main TAVR before the procedure. The majority had it before 3 months. The majority was ostial left main, and also the majority was unprotected left main. Again, the signal of major vascular complication and bleeding was higher if you had a pre-TAVR left main, but the mortality was the same. More importantly, from this registry, not a trial, is the fact that, unfortunately, if you have an unplanned left main PCI during TAVR, then you will have worse outcome compared to somebody who have a pre-TAVR, and the main driver for this is because they have left main obstruction. So for us, if we are to address left main outside ACS, it is safe pre-TAVR. We have to dwell in the selection of the valve and the timing of the procedure to minimize the risk of bleeding in relation to depth. Now, to summarize this part of the talk, still the assessment of the left main severity is very important, especially in stable patients. Predicting the valve type is very important if you're going to plan the revascularization post-TAVR. For most left main disease, more than 70%, or who have significant stenosis per imaging, I think PCI before TAVR is safe based on the available data. For borderline left main disease, you might consider to defer, but keep in mind your choice of valve. The second part the operator face is coronary obstruction in relation to a TAVR for a normal left main, and this is where the task of prediction and risk mitigation becomes very handy. I just start by 2 cases, one for a native valve, an area of 390, an SOV of 28, a left main height of 9.6, with a leaflet length of 16.4. A second patient is basically a patient of a redo TAVR. The initial TAVR was done 2019, small annulus 377, small sinus in general, and the left main height is also in the short side, 9.4. Second patient underwent her initial TAVI using an accurate Neo size 2, and exactly 5 years later, she developed structural valve deterioration manifested as AI. So I will come back to both cases at the end if you add 2 additional minutes to my talk. That's how I can guarantee my additional 2 minutes after the talk. No problem. So the incidence of coronary obstruction is very rare, luckily, in native TAVR, around 0.5 to 1%. But unfortunately, the mortality is very high. The same suspect, the valve to virtual valve to coronary distance less than 4, leaflet length in relation to coronary height, and the coronary height becomes the usual predictor we use. But all of us, we look at this and we ask the question, are they fully predictable or not? And I will show you towards the end. For valve and valve, the message is the same, but the risk is higher, almost triple for the incidence, and the mortality is the same when we compare valve and valve TAVR versus native valve. So does the mortality or does the incidence of the coronary obstruction has changed over years? Absolutely, the incidence has been the same, 0.8% from the Spanish trial, which is the largest so far, and it come up with the same risk factor, coronary height, sinus of valsalva less than 28, the bulk of calcification in the left leaflet length, and a VTC less than 4. But the additional fact is now you have some more clinical information to discuss with your team. If you have more than 1 risk factor, your chance of obstruction is almost 32% for native, and almost 78% for valve and valve. The mortality is high if you develop coronary artery obstruction. More importantly, when we discuss where is the obstruction happen, we really have to do our diligence in relation to the pre-TAVR assessment. The obstruction can happen by the valve at the coronary level or at the valve as the STJ. And to the right of the screen, there is a well-published algorithm, and you definitely can use that whether or not you have a leaflet that extends above the coronary ostium. If you have no for that question, probably your risk is low. And then you go down the algorithm to incorporate the VTC and subsequently the VTC to STJ. This came from only 50 patients. More importantly, which is this recently published, and it has a very high predictive value, as I will show you, is actually it will incorporate the cusp height in relation to the annular plan and the left main height. And this is the only trial so far that come up with a predictive value to the amount of calcium. And I will show you this in the result. So they looked at 60 patients who had coronary obstruction and they compared them to almost 1,300 patients who did not. The risk of coronary obstruction in this study was almost 27%. And the usual suspects, small SUV and small coronary, low coronary height. But more importantly, when they applied each of the individual factors that we look for at the coronary assessment, for example, left main height, SOV less than 35, all this did not come with a higher sensitivity and specificity compared to the other risk factor, which is a cusp height more than the coronary height, in addition to a VTC less than or equal to 4, and a culprit leaflet calcium more than 600 millimeter. Now, having said that, this is the only model that this has such a higher predictive value in terms of sensitivity and specificity. So this is very important for us to use. But the caveat is for patients with fibrocalcific aortic stenosis, which is prevalent in our area, the calcium score might not be of help. So how to mitigate? This is very important, the heart team discussion, surgical versus transcatheter. The chimney technique has its drawback. It is definitely, compared to no protection, provide a significant safety, and for patients who have a high risk for coronary obstruction, the odds ratio, if they did not have chimney, is 8.8 to have more mortality. A second is the basilica, labor intensive, definitely a learning curve in this procedure, but it is protective and 93% risk, 93% success, but the caveat is a higher risk of stroke. Now, to modify the fact that the basilica, if you allow me 2 minutes, to modify the unicorn come up with another technique specifically to increase the splay in the leaflet because the basilica generates a slit. The balloon technique ensure that there is a wide open leaflet in front of the coronary ostia. Now, how do they compare? Definitely when you compare the basilica to the chimney, the risk in terms of mortality in 1 year, this is just a comparison, not a randomized trial, comparable in terms of MACE, but higher risk of stroke with basilica, and definitely high acute kidney injury and contrast use. Now, a dedicated device is not currently available. It's in use in the US, but it's not currently available in our area, which is the shortcut. Now, back to the two cases. The first case, which is the native valve, our mitigation strategy was just protection, and patient had a successful deployment of a valve with no obstruction, and we can easily engage the left main post. The second case had so many favorable features not to mitigate. So the VTC to the left coronary artery was 5.2, right coronary artery is 7.6. The VTC STGA in the right was favorable at 5, maybe borderline at the left 3.7. As such, we elected to protect the left side. This is a failed accurate NEO 1, so it was pre-dilated. We protected with a guide liner and a stent ready in the left system. Deployed the valve. Post-deployment, we did not need to deploy the left coronary stent, and basically everything was removed. The mechanism was AI, so we were not worried about leaflet overhang. This is the echo result post with no more AI. So in conclusion, coronary obstruction is rare, but unfortunately lethal, especially in TAV and TAB. A CT-based prediction is very important, and the prediction model is getting better and better. Mitigation is whatever you are comfortable with. Definitely basilica will be in the rise, and more importantly, a shortcut. And a heart team is very important to divert patient towards surgery if needed. Thank you.